Hi, good morning. I'm Joe Ciotola. I'm an orthopedic surgeon from Mercy Hospital, and in this segment I'll talk to you about shoulder arthritis. So shoulders are the fastest growing joint to get arthritis in the country now. We're seeing a higher increase in the number of patients with shoulder arthritis for some reason. This has been a trend over about the last 5 years or so. It's still behind knees and hips in terms of prevalence, but it is increasing. And we're not sure exactly why. What arthritis is, similar to the knee and the hip, typically osteoarthritis of the shoulder is where the cartilage on the end of the bones wears down. And this causes pain and inflammation and stiffness and can become very dramatic at times. Solutions for patients who are suffering with arthritis of the shoulder are varied. We start with the non-operative therapies, just like we do with all arthritis, and that is anti-inflammatory medications. These would be similar to Aleve or Advil, and then we can add Tylenol to that as well to help patients. Once they have tried that and maybe tried some physical therapy, if they're still suffering, then we go to injection therapy, and that would be cortisone injections. Typically, a cortisone injection, however, only lasts about 6 weeks, and it's recommended that you don't get more than 3 of those a year in any one spot because it can cause degeneration of the cartilage even worse and weakening of the soft tissue over time. So if the patient is becoming stiff and has exhausted these conservative measures, then we look for a surgical option for them. If they still have some preservation of their joint space and they're young, we can do an arthroscopy or a shoulder scope, which is a minimally invasive surgery done through small incisions just to clean out the arthritic debris, clean out the inflammation for the patient, and put some anti-inflammatories in there. And that can give patients with mild to moderate arthritic shoulders symptomatic relief, and it can last several years. If it gets to the point where they get very, very stiff and there's no joint space left, then we're left with resurfacing or replacing the shoulder. And I have behind me examples of that. We do 2 types of shoulder replacement, a primary shoulder replacement, or there's something called a reverse shoulder replacement. The reverse shoulder replacement is something that we use for patients who have very arthritic shoulders or shoulders that are not functioning because they do not have an intact rotator cuff. The rotator cuff is a confluence of tendons that come from 4 different muscles that help stabilize and move the shoulder. And it's a very commonly injured muscle tendon that if it's left unrepaired and the shoulder goes on to become severely arthritic, there is not a good solution with a primary shoulder. So there was invented something called the reverse shoulder to help those patients. Behind me here, this is an example of a very arthritic primary shoulder, where it was just the bone between the humerus and the glenoid that had worn out, just the cartilage that had worn out between the humerus and the glenoid. So it was resurfaced with the metal head ball, similar to what the metal would look like. Similar to what the bone and cartilage would look like on the primary shoulder. And then there's a plastic disc similar to what would be the shape of the glenoid or the socket. So that is an example of a primary shoulder. This patient has not only glenohumeral arthritis, but you can see that the humeral head has ridden up superiorly and is rubbing on this bone called the acromial bone because the patient has an incompetent or failed rotator cuff. And these bone spurs here and these cysts in the bone here are all typical findings of a patient with an arthritic shoulder. This, I'm going to switch, this is an x-ray of this patient after undergoing a reverse shoulder replacement. And it's called a reverse because now we put the ball on the socket and the socket on the stem, or on the arm portion. And this is a more constrained construct. So what that means is it doesn't require the rotator cuff or muscles or soft tissues to hold these 2 parts together as well as a primary shoulder does. And this allows the center of rotation to stay in place, so the patient can pick their arm up and get to their hair and get much more mobility by using their deltoid muscle on the outside of their arm. So this has been a wonderful advance for patients with shoulder arthritis who also have rotator cuff tears. Thank you.